Hey everyone, so I am here at the Austin at the Repat with Dr. Alex Craven, and it's been way too long since our last catch up. Alex, thanks for joining us on the Bari Chronicles.
Always a pleasure. It has been way too long, and that's mostly my fault. So sorry, man. It's yeah, it's good to catch up again. Welcome to the glorious repat in all of its war hospital glory.
Yeah, so for those of you who don't know about the Repat, it's part of the Austin Hospital Network. Um, it was originally a war hospital, even have bomb shelters, the whole works.
Yeah, I think there's lead line walls in some spots. Wi-Fi is horrendous. You got to sort of stand near a window to answer a phone call. It's full on, but it's a cool spot. It's got a bit of a Uh, it's an important place to me. It's nice. So part of the networks, yeah, but this is where we have our surgery center, and that's where we do sort of more of our higher volume, lower risk surgery, including most of, nearly all of our metabolic bariatric surgery for our public bariatric surgery service. So this humble little hospital actually contributes a substantial amount to, I guess, the national uh, delivery of obesity care. I don't think we're doing enough, and we want to do more. But yeah, it punches well above its weight. This little place.
Yeah, and I think that's really special that we've got this in Victoria. And to me, it's a bit of an example of how more of our states should be looking to care for people living with obesity because, you know, just talking about it really isn't enough. We all hear the campaigns and the eat healthy, move more sort of stuff, which hasn't worked for the last 30 years and I don't think is going to start working now.
I think, yeah, I think it's that classic thing where it's a false choice. The idea is, oh, you can move more or eat healthier or treat obesity, and you're like, well, you remember that ad with that little girl, Percanellos Dos, the little girl with the
Yeah,
taco ads? Why not both? And I think it's a perfect example. And I think, you and I have spoken in the past about how there's this idea that eating less and moving more treats obesity. Actually, treating obesity helps people eat less and move more. We've had that relationship backwards for too long in this country. I think the other part of that is that when we look at this thing we call obesity and how much people really have control over in terms of voluntary decisions about things like eating less and
yeah,
moving more. I kind of package it up into about, you know, 5 bits, of which I think people have partial control over about one.
yep,
Yes, there's some lifestyle stuff, the things you choose to do in your life. Absolutely. There's also genetics, hugely impactful. There's also development. And so stuff that happens in early childhood, stuff that happens in the womb, even stuff that happens to your parents before you're conceived, even to the point of stuff that happens to your grandmother that affects you when you're still an ovary inside your mother,
wow,
right? We go back
yep,
that far and we can trace impact. All that development stuff has impact on what we call epigenetics, which is the way genes are turned on and off. So there's the genes, but then there's also which genes are turned on. Then we've got medical conditions and hormonal factors, puberty, menopause, thyroid problems, medications you go on, mental health issues, stress in your life, all those sorts of things that impact us all very differently. Again, you have limited, often no control over. Then there's our environment. And yes, I will accept that we have some partial control over our own little microenvironment, like the
yep,
things we bring into our house, and those kind of things. But we don't have control at a personal level over the bigger environment, this whole obesogenic environment thing we talk about. And that in itself is hugely complex. So you've got lifestyle, genetics, development, medical and hormonal conditions, and the environment.
Yep.
And I reckon you've got a modicum of control over your environment. And yes, you have some control over your lifestyle, but some of that is also heavily affected by all the other four. Your lifestyle is dictated to a certain extent by your environment.
Yep.
Genes and the diseases you carry dictate what you can do with your body, et cetera, et cetera. So this idea that, oh yeah, I can just go and do stuff. There's nowhere in medicine where behavior directly affects physiology.
Yep.
Nowhere. And that's assuming that we have 100% control of our behavior all the time, which we don't. Otherwise, there'd be no field of psychology. So this whole thing is so much more complex than people talk about. And you sort of have to get, you get put in this camp of, oh, this guy doesn't believe in diet and exercise. Bollocks. I talk about diet and exercise all the time, but I give it space where it deserves space. I'll talk about it because there is a dose-dependent relationship between exercise and health. So I want people to exercise. It doesn't treat obesity very well. It's really good for you, so do it. Just don't do it to treat obesity. And when you're concentrating on your exercise, look at how much exercise you're doing. If you're doing, enough exercise, think about a mix of resistance and aerobic. Do all of that stuff, but don't look at it as a weight loss thing or anything else other than health-promoting exercise.
Yeah, it's just good for you.
Yeah. And so all that sort of stuff. And the same with the diet stuff. There's so many good things you can do with diet. Eating more veggies, money in the bank. Getting enough protein, money in the bank. As long as you're getting the resistance stimulus as well. Shifting from animal-based to plant-based fats, all great things. Yep. Will have minimum to no measurable effect on your body weight or metabolic disease profile, but very good for you anyway. Yeah. And that's okay. You're still doing the right thing if you're doing those things. And I think then we just wrap it up in.
And so that's where we can sort of look at just in general, a person who might be overweight or living with obesity, but they can still be healthy in that they're eating healthy, they're still exercising, but the weight just doesn't shift. And that whole, I guess, almost putting shame on people as if it's some sort of personal failure. But you could have the healthiest diet and do your 40 minutes of aerobics a day and still be classed as overweight or obese. And I was flicking through Instagram this week and I saw this amazing guy from Western Australia, and he's trying to manage obesity, and he was starting a challenge, some Instagram or TikTok weight loss challenge. And when he was talking about it, I sort of felt sad for him. And within 4 days, he puts a post up talking about how he'd failed because it had been a really hot day or something, and he hadn't gone to the gym that day. He didn't feel up to it. And so he'd failed this challenge. And I'm there thinking, you missed one day and you feel like you have failed. We put so much pressure on ourselves unfairly because even your fittest person will have a day occasionally where they miss going to the gym or.
Yeah, more than that, your professional athletes will have a schedule that deliberately includes rest. Your professional athletes will have a schedule that keeps most of their training and exercise at moderate intensity levels to lower the risk of overuse injury and incident injury. So if
Yeah.
you're training a professional athlete, a lot of this challenge stuff and a lot of things that you'll see, you would not do that with a professional athlete, because that is a high, like, I don't want to make an professional athlete sound like a product, but that is a precious resource, and so you
Yes.
wouldn't damage that.
Yeah.
From the point of view of it, if you understand the science about this too, I think that explains away a lot of this perception of failure is just sort of misses, I guess, the science and biology. I think the best way to think about the effect of exercise is just accumulated dose over time. So when you look at an exercise program, there's this wonderful guy from States, Dan John, talks about not training. He talks about his rule of twos, and I'm going to muck this up, but don't worry about what you're doing today. Worry about your exercise, how your exercise today is going to affect tomorrow, 2 years, and 20 years' time.
Yep.
Because when you're doing this, ultimately, if your exercise today is twice as good as another regime, but you stop it, versus if it's something that is half as good and you can continue that for the rest of your life, that's where the value is.
Wow.
And so it's this accumulated dose thing. Now, and so what that means in people's lives is very different. I kind of swap around from fad to fad personally. Like, I'll be
Yeah.
getting into one thing for a while, and then I'll kind of fall off and I'll do another thing for a while. And it's very easy for me, I've given up on that again. I've given up on that again. I've given up on that again. And it's really easy to give myself a hard time about that. But actually, if I look back, I'll be like, you know what? If I'm thinking about what I did versus instead of what I didn't do, actually,
Yeah.
I got some stuff done.
Yes.
And your body knows what you did do. It doesn't. Your body doesn't know what your body never sees the exercise you don't do, and that's the thing. We get caught up in, oh, I'm not doing this, I'm not doing that, I'm not doing high intensity cardio or this or that or whatever. Your body doesn't know what you're not doing. Your body only knows the exercise that you do,
But it
and
does affect our mental health when
big
we're
time.
going, oh, I didn't do that, I didn't do that. And we see it so often where people are feeling so condemned because they haven't done something, or, maybe they did do something. I had someone talking to me last week, and they'd been to Macca's. They were so upset with themselves because they'd been to Macca's. And I said to them, it's one meal out of millions that you'll eat in your lifetime. How was it different to what you would do before surgery? And it was different because they had like half a cheeseburger. And before surgery, it would have been a Big Mac with nuggets, large fries, and anything else. And I think we can put so much condemnation on ourselves, but the change is incredible.
Yeah. So there's a couple of really good lessons to unpack from there, and one is the comparisons we make.
Yeah.
And so one of the things whenever I meet a patient, private rooms, public rooms, whatever, if they're going on this journey, medical or surgical, starting medications or having surgery, I really try to get them to look and take a snapshot and record what's happening now. Because part of human nature is we keep resetting what we consider to be normal.
Yeah.
So, and so classic example is weight itself, right?
Yeah.
When someone first comes and sees it, at their highest weight, of course, when you hit that lowest weight after surgery, that becomes where you readjust. And so for the rest of someone's life, someone's looking at, oh, geez, I weighed 70 kilos and now I weigh 75. And there's no one's looking back at the start of the journey long in the past.
Yeah.
We're like, well, hold on, here's where I started, here where I am now. I had diabetes, now I don't have diabetes. I had pre-diabetes, now I don't have diabetes. Or someone comes to you with diabetes, everything's going well, the pre-diabetes comes back. No one's thinking, oh, I've got pre-diabetes instead of diabetes.
Yeah.
They're thinking, I've got new prediabetes because we've reset our expectations. And it's human nature. But it is something that we can reframe and look at. And so oftentimes, you know, we forget to really take that snapshot. So I reckon if that person really looked back and said, well, you know, I'm beating myself up about what I'm eating now.
Yeah.
If I looked at what I was eating at the time that I was least happy with my diet,
Yeah.
and looked at now, you know, if I was that person and looked at this person, if I was past me and I looked at current me, I'd be bloody impressed.
Yeah.
But we've reset our expectations and adjusted accordingly. And it's all sorts of things. It's like our physicality. How do we move? What things hurt? What medications are we on? There's the thought processes that people, oh, my hunger's come back. You're like, yeah, have a think about your hunger 2 years ago. Oh, yeah, actually, no, my hunger's okay. You know, and so all these sorts of things, you know, the food noise thing and all these sorts of things that people are like, oh, it's because we've reset our expectations. Now, the interesting thing about the biology of this is when it comes to measuring the impact of obesity treatment, medications or surgery, the measuring from the start to where we are now is actually the best predictor of clinical effect. So what I mean by that is if we look at where someone is in relation to quote unquote normal BMI and all that sort of stuff doesn't really help us now figure out how much have we helped that person or how much have they helped themselves. But if we look at the starting point and where we are now, that's a really good indicator. And so I do that to patients partly because I know that it's going to help their mental health potentially. But from a medical point of view, I do that because it actually is the right thing for me to do as a doctor to know how things are going. You know, if someone, and the problem is that really hasn't got into society, you know, 20% total weight loss, massively impactful. Now, it's not that the weight loss is the thing, it's just that what it takes in terms of changing someone's metabolism to create 20% weight loss is a really big deal for their overall health. So the weight is one of the outcomes, not the cause of the health benefit. But so that is a reasonable way to measure things. Problem is, if you start at 200, get to 160, the whole world's looking at you in one way. If you start at 100 and get to 80, still that 20%, still measurably in the studies that we look at, same health benefit, but one person is looked on by the world as a failure, and one person is looked on by the world as a success. One person is looked on as someone that's got lifestyle problems and is doing the wrong thing and isn't, you know, exercising enough and is eating too much, and the other one's getting pats on the back for their wonderful lifestyle. Except no one's actually spoken to those patients or taken a food history or taken an exercise history and has any freaking idea what's actually going on in their lives. And so that's, you know, we just step after step of these misconceptions and mythologies out there that really, and it wouldn't bother me so much that, except it really impacts people. It derails people. And I'm personally, it's my philosophical opinion, but I think I have enough evidence now to say that you don't need to sacrifice your mental health or your relationship with food and the people around you to get really good obesity treatment. In fact, really good obesity treatment, as part of it, one of the foundations of really good obesity treatment is preserving people's mental health. Part of the foundation of really good obesity treatment is preserving people's relationship with food and the world around them and their social supports. And that's where I get really worried about a lot of the stuff that's out there. Because, you know, you look at this and you're like, hold on, this program contains elements in it that we know to be bad for mental health. This contains elements in it that we know to be bad in terms of dietary exposures that are not good for you, that we know to be bad in terms of potential for causing eating disorders. You know, all that sort of stuff's out there, and you say, well, hold on. And so, you know, when we look at making plans, that needs to come into it, you know, and so we look at healthy relationship with food, the RAVES model from the eating disorders world. We make sure that those foundations are in our programs. We make sure that the basics of health promoting dietary patterns, not just eat less no matter what, but health promoting dietary patterns supported by good care, rather than just chasing weight loss at the expense of all sorts of other things. And it's a very fulfilling and fun way to practice medicine, because you can have the best of both worlds. You know, if you do this right, then your patient can have regular, adequate food intake. They can eat a variety, they can enjoy food, they can eat socially and spontaneously without all of this guilt, but without doing themselves metabolic harm in the long term. You can actually have that. It can be tricky to set up. It can take a lot of work. It can take a lot of unlearning of previous bad advice, but you can do it. And it's bloody great when you do.
See, I love that, because I know for me, when I had my sleeve nearly 12 years ago, I thought I was going to have to give up certain foods for the rest of my life if I wanted it to work. And that scared me going into surgery, going, how do I celebrate, Christmas or Easter or birthdays, or, how do I celebrate that if I can't eat again? And nearly 12 years out, I realized that those one-offs don't really affect anything other than my mental health. And now I can go, I'm looking forward to Christmas. I'm looking forward to trying something that, we wouldn't normally have. Kim and I have been having date nights, and we try a different sort of cuisine each time. And, I found stuff that I do like. I found stuff that really doesn't sit well, and actually my body just completely rejected this one type of meal. And I'm there with a serviette in the restaurant spitting it out because I could not swallow it. My body just went, you're not having this. I'd never had that before, but it happened, and I was like, oh my gosh, this is so embarrassing. It tasted good, it's just my body rejected whatever it was.
But do you regret that in the long run?
No, I don't.
No, you should.
Kim and I look back and we laugh about it and go, we won't do that again. But I'm really enjoying that. And sometimes we just share a meal because I can't necessarily eat a whole, depending on what it is.
Yeah.
So we'll try and find something that we can share, or we just don't eat it and have what we want and are happy and satisfied with that.
Yeah.
But it's not controlling my entire life anymore, which is what it was when I started. I didn't have anything sort of classed as a dessert for nearly 18 months. And while, that helped with, I guess, with some of my weight loss and that, I didn't really eat that much sweets anyway, and I realized I was just restricting myself for no good reason.
Yeah, and that it's part of this mythology, and again, the mythology wouldn't bother me if it didn't stand in the way of people living longer, healthier lives. Yep. So, look, I don't think I'd so be built up about this, except we sort of embrace this mythology that metabolic surgery heavily restricts what you can eat. It doesn't. That, you have to tiptoe around and follow this strict diet. No, actually, often it provides freedom from dieting in a way nothing else can. That it is extreme or dangerous or expensive. It's extremely effective. What's dangerous is leaving someone with type 2 diabetes. What's dangerous is leaving someone with failing kidneys, metabolic associated liver disease, and all of the other things that predictably come from not doing effective therapy. And so the bit that sort of drives me nuts is this mythology's out there and it persists. But what it means is that being there is one more thing where someone who really should have had a balanced, objective discussion with someone like their GP and said, look, really, the thing to keep you alive the longest and to decrease your burden. Oh, and by the way, not just decrease your burden of disease, but also decrease the amount that taxpayer money needs to spend on you to keep you alive. So, that's the expense thing that drives me bonkers, because part of the value and the reason we run this service here is by far the most cost-effective way to treat the patients we treat. So all this is there. And so instead of that conversation happening, the predictable result is people get offered the quote unquote safe option, which is actually the least effective thing, which is the thing that's most likely to keep them, acquiring more and more risk of disease, more and more disability, more and more deaths. And that's paralyzing our healthcare system at the moment. And in doing so, because they are given unrealistic expectations and a set of tools that are not up to the task of meeting those expectations, you just drive someone's mental health into the ground. There is only so long, and really the only choice then for people, I think, realistically, is you either have to give up or you have to walk away from healthcare. And because this cycle of it's all responsibility, no agency. This is all your fault. Here's an ineffective way to try and deal with this. It's all on you. Versus, let's be realistic. The amount of this that is your fault is very small. Most of this is biological. And even if it was your fault, by the way, things are already happening throughout your life. Even if it was 100% your fault, things have already come to a certain point. If I get drunk tomorrow and crash my car, that will be my fault. I will go to the Alfred Hospital emergency trauma session, and they will spend whatever it takes in terms of resources, money, expertise, equipment, nursing, medical, the works, to return me to the best physical health they can. It's a phenomenal institution. They do an amazing job with trauma there. St. Royal Melbourne. Beautiful. We've got a phenomenal state trauma service here, even though that's entirely my fault. So even if, and it's not, but even if it was someone's fault, we would not just say, good luck, it's all on you. They're not going to say, well, you crashed your car, go and fix it yourself. They accept the damage is done and we step up. So even if you're not willing to accept this is not a matter of personal fault, it is still unique that we do this. We don't just say, oh, I'm sorry, you smoked, you've got lung cancer, sorry. Go and try dying. Yeah, just stop smoking, good luck. We don't do that. So
not losing weight faster, or and it's like you're eating like 2 or 3 tablespoons of food. That has nothing to do with your weight loss.
Yeah, look, it's. I think this is where the medications. I'm so glad we've got effective medications now. Yes, they're not as effective as surgery. Yes, the cost-benefit analysis on that is problematic at the moment. I think that'll get better. As you know, I'm a big proponent and a big fan of obesity management medications, and freely and willingly use them with my patients, and will continue to do so. But I love them as a clinical tool. But what I also love is to understand how these work. You have to start thinking about how body weight control works. Because if you think about these medications as an appetite suppressant, it kind of doesn't make sense when you're on the medication and some of your appetite comes back. It doesn't make sense. If you think about these as a weight loss medication, then you stay on them and your weight plateaus, you have to really think about, well, why is my weight plateauing while I'm on this medication? You really have to, and so then that leads us to peel back the layers and say, okay, well, hold on, there's this really complex whole body system here that is controlling, if you like, our energy state, how much energy we're carrying and how we're using that energy. And that's not under voluntary control, because if it was, we would all die. We just could not voluntarily control that. We just couldn't. It's too complicated, involves too many organs. We would spend our whole time thinking about metabolism and we'd die. So this is all going on. And it is an effective set of systems that for most of human history kept us alive because we didn't have enough food. And so someone had to take the reins, and it was our lizard brain got in control and was like, right, dude, whenever we're getting to food, we're stacking that on to get us through the hard times. And we're going to create this, constant hunger drive and drive to get bigger so that in the times that we've got nothing, we just might pull through. And we're in a radically different world. And that's all going on. And that doesn't change and that doesn't go away just because you're taking medication or just because you've had surgery. But, and we can't take away the genetics of that and we can't change the environment of that. But what we can do is impact on that system, on that control system. And so, people too often think about surgery in terms of the anatomy. I'm a surgeon. I'm supposed to know anatomy. I'm supposed to talk about anatomy. Unfortunately for this, I've got to tell you that the anatomy is not where it's at. Metabolic operations we use these days work because of the hormonal and neurological effects, the nerve effects, the hormone effects they have, and the way they impact that whole body energy control system. And honestly, they do it in a way that we haven't fully figured out, that we don't have as much control over as we would like as surgeons or as patients, and in a way that varies according to people's genetics a lot more than we may like to believe, but they work really well. And so what they do then is change the relationship, the hormonal responses to food and the way the body responds and the way it controls its body weight. And part of that will be controlling appetite. And part of that will be early satiety, less food to feel full, all that sort of stuff. But a whole lot of other things are going to go on in the body that are unrelated. Diabetes gets better. A lot of my patients that have a bypass, the diabetes goes away on the table during the operation and never comes back. Right? It goes into remission. I'm not going to call it cure because it's I don't think it is, but it just goes away. That didn't happen because they ate less, because on the operating table, they're between meals, they haven't actually started eating less yet, right? Other stuff, and that's just one example. We've got all sorts of other examples. A lot of people find within 2 weeks of this operation, their joint pain is radically better, radically, stunningly better. That's because what's going on in the body now has changed the inflammatory response to those joints. It's not the 5 or 10 kilos they've lost, because they've lost 5 or 10 kilos after, without metabolic bariatric surgery in the past, and everything still hurt. There's something else going on here. Same with metabolic liver disease and kidney disease and all the other stuff. So there's so much more going on than eat less food. And eat less food is a thing, and people just want that sense of control. And that is a very positive aspect of the surgery of the medications. It's just restoring control. But there's a difference between restoring control and then taking that control and torturing yourself with more restrictive dieting. And I think it's fair to say that restrictive dieting plus metabolic surgery sometimes has a role, like having heavily calorie restricted and doing all those things sometimes have a role, but it certainly comes with more nutritional risk. It certainly comes with more psychological risk. So you want a really good reason to do it. I think you really need to be doing that hand in hand with a dietitian and a psychologist, with in a situation of as a pretty extreme measure for things like uncontrolled heart failure or the impossible to control diabetes and all those sorts of things. Like, you really want to go into that with your eyes open, because you will do psychological harm if you're not careful. You will do nutritional harm if you're not careful. I think that's how metabolic bone disease, osteoporosis and those things happen. For most people that I meet, the impacts of that metabolic surgery, the metabolic impacts of the surgery, are enough. And the only reason that they're not enough is sort of that societal pressure to be smaller at all cost in a lot of the people that I meet. And a lot of the conversations I've had with people, often there's tears, because we sit down and when we reframe perceived failure as success, when I show them the evidence of what should be happening, and in almost all circumstances, they're well ahead of, because it's high achievers that are freaking out, right? It's the people that set strong goals, overreach. High achievers are the ones that feel failure. That's the other thing too. People label themselves as a failure. If you are feeling failure, that's because you had a goal. That's because you overreached. That's because you tried for something, right?
Yeah.
So that's what the flip side of that is. No one actually thinks about, why do I feel like a failure? Because you set a goal and you went out to achieve it. You don't feel failure if you don't set a goal and go out to achieve it, right?
True.
You know what I'm saying? Come on, man. Like if I'm lax, if I'm floating through my life, I'm not going to feel a failure if I'm floating through my life aiming for nothing.
Yeah.
You don't feel failure. Happy as, right? So when I sit down with these people and I actually reframe, oftentimes it was not the failure. In almost all circumstances, when we sit down and look at these things, it was either unrealistic expectations or methods where there was clear evidence that it wasn't going to do that thing that we'd set out to achieve.
I mean, I know I was upset when I hadn't lost sort of 100 kilos at 6 months. And I was there thinking, I'd lost over 50.
Yeah.
And I was feeling like I'd failed and wasted my family's money and everything else. And I was like, when was the last time I lost over 50 kilos ever?
And you felt like who had failed?
Yeah.
You, right?
Yeah.
So I want to rewind this a little bit, right? So we know that most of the evidence on average, really good sort of lifestyle and dietary interventions, about 1 to 5% weight loss at 1 to 2 years. Maybe a bit more, 5 to 10 in the short term, and then coming back.
Yeah.
Metabolic bariatric surgery, sleeve, average about 30% total weight loss, right? So 6 times as much conservatively, 6 times as effective. But you blamed yourself.
Yeah.
So the surgery has 6 times more power in that equation, right? That the metabolic effects of the surgery are 6 times more powerful in that sense. And so if there's 6 of them and 1 of you, right? Yeah. You're on a 7-member team and you didn't win the game, not all your fault, bro. Yeah. And I think that's the thing, and unfortunately we've conditioned people. Now, I'm not saying clearly the surgery didn't fail either, right? Clearly it didn't fail either. That was an issue of expectations for you, and you know that, and I know that. But just watch what your mind did in that circumstance. We've so beaten people down with this unrealistic expectations of what they should be able to achieve by themselves, so they instantly jump to failing. Yeah. Like I don't think they should blame anyone. I think they should have realistic expectations, but for goodness sakes, I think it's probably more protective of your mental health to blame the operation than yourself.
Yeah.
You know what I mean? Like if you're going to choose blaming someone, don't blame yourself.
Yeah. I mean, I remember the conversation I had with my surgeon at the time before I had my sleeve. And he said to me, Damo, how would you feel if you only lost 20 kilos? And I was like, well, will that make a difference to my health? And he's make a massive difference to your health.
Yeah.
It'll be amazing. You won't notice it. And so I was like, okay, well, I can do this if it's only 20 kilos. But then when I hadn't lost the 100 kilos,
right.
I was pissed off.
Yeah.
I was like, what have I done? I'm doing something wrong. I remember when I first, it was after surgery and I didn't lose anything for the first 8 weeks. And I was like, what am I doing wrong? It's nothing to do with the fact that I just had 80% of my stomach cut out and was healing and swollen and everything else. But, I've screwed this up. I'm 8 weeks out. I haven't lost anything and I've fucked it up already.
Yeah.
And that was my mindset. That's my default setting was I fucked it up. And then suddenly the weight started coming. And it started coming off faster. But I was never satisfied. And even then, when I'd lost the 100 kilos, I still wasn't happy with how I looked because I had this ridiculous image in my head of how I should look at when I was 90 kilos. And I'm going, I'm still not happy.
And this is why I surround myself, like, this is why every one of my private patients see one of two psychologists that I know really well and trust, and a few others around the place that I've, there are others that I'll, that I'll regularly work with, but I got to know who that is, and why everyone in my private practice sees one of two dietitians that I've worked with for years, even if they have another dietitian, another psychologist, because the reason I do that is not about motivating people and making sure they're going to stick to the diet or ruling out eating disorders or any of that other stuff. The reason I do that is there's so much value in seeing this early, putting a mirror up to this early, and letting people come into this with a bit of unlearning first. Now, the trap's still there and people fall into it. Self-blame is just part of the human condition. But that's where that's at. And I think a lot of people have this idea that, the dietitian's role is to keep you on track, to keep you motivated, all that sort of stuff, to make the surgery work. Oh, God, no. I use a dietitian because the thing that I do works so well that we have to flip the switch. We have to go from how do we make you eat less to how do we make you eat enough. We have to go from, let's make sure that our portions aren't too large to let's make sure our portions aren't too small. We have to go from let's make sure that we're not eating too often or snacking to let's make sure we're eating regularly every day, right? Like, and we've got to, and everyone comes with their own mileage and their own baggage and all that sort of stuff. And so that, like, because it really works, because it has a profound lifelong impact on someone that I need to manage. And this is the thing that people who have been sort of throwing the medications out into the community without working with a psychologist and dietitian, they're starting to discover this. Because in the randomized controlled trials of the medications, they didn't have this problem because you were seeing a dietitian every 2 weeks, and you had all this wraparound support and everything was fine. And you deliberately chose a group of people that had the free time in their life to engage in a medical trial. No one's got that free time in the real world, right?
No, that's right.
No one can be, no one can be seeing a dietitian every 2 weeks. And it just doesn't happen, right? And so now oh my gosh, I can't just give someone a script and a ChatGPT generated diet plan. That doesn't work.
And, we've been seeing that more and more on BSA is people saying, go on ChatGPT, get it to do you a meal plan. And I was just like, don't do that. Chat can be good for some stuff, but, we're talking a medical procedure that we've had, surgical intervention. You need someone experienced in that area to at least get you off to a good start.
And the problem we have with the AI stuff is it's phenomenally good technology, but remember that AI learns from sort of popular vote, and this is a niche area. We've talked about the mythology that dominates most of kind of medicine and society here. So the input that AI is learning off when it's telling you how to eat after metabolic surgery and doing all those sorts of things, what it's learning off is pop culture. Just because it's seeing all this stuff. It doesn't, and I hope over time that'll evolve. That people will understand, okay, well, the role of eating as a part of good obesity treatment is not about forcing more weight loss, but is about ensuring regularity, adequacy, variety, enjoyment, and spontaneous eating, and ensuring that happens every time. The role of, nutrition here is to ensure that as we treat the underlying metabolism, we fuel lean mass and all the rest of this. ChatGPT hasn't learned yet that there is a difference between the psychological support to motivate towards caloric restriction versus psychological support during your first time on an effective therapy,
Yeah.
where you may or may not have a history that has created some problems with your relationship with food, problematic eating behavior, even eating an eating disorder that hasn't been recognized because your body is large, and the eating disorder world is kind of slowly catching up with this.
Yeah.
And this isn't out there enough that ChatGPT has enough input
Yeah.
to do this. And so, and that's just not the AI. These are also the conversations I have with government. This is also the conversations I have with hospital administrators and with these are the things we teach in courses to experienced doctors and experienced dietitians and psychologists, because we're not at the, and it's mainly the stigma thing, because no one, everyone gets trapped in this cycle, and you think you understand obesity, so you don't bother looking at the evidence as critically as you could, all that sort of stuff. And so that, that, again, it's all that mythology. And it feeds a lot of these algorithms, and it feeds a lot of these diet plans made by very intelligent, sensible people, just without the frame of reference that I'm only lucky enough to have because I ran into the right people. And I don't have this frame of reference because it's taught well in medical school or during medical or surgical training. I landed at this hospital and learned how to cure diabetes. I landed at this hospital and had to sit down every week in front of people who were in a safe space where they felt they could really tell me about their experience of this disease. So I learned all this from my patients. Then I was able to go back and go, whoa, this is not right. I remember being furiously angry. I'm like, they've betrayed me. What I was taught about metabolic health, about obesity, doesn't fit with these patients. And I can still remember a number of patients that really challenged my beliefs on this, just because these were effective, powerful people that could do everything else but fix this. And I really had to stop and go, no, this doesn't work. I can't blame this person. And there's got to be something I'm missing here. Then I find there's 20, 30, 40, 50 years of evidence making it very clear, right? But you don't know what you don't know, so you can't explore that. And so then you end up in your tribe. You've met a lot of this group, the guys from around the country that are just into this. And I'm going to be honest, when I first got into this, it was like screaming into the void. It's like, why the hell doesn't anyone else get this? Is just the same as the rest of good medicine. I was furiously angry. I felt like I'd been betrayed. That institution that was supposed to prepare me to help and not harm people, supposed to prepare me to be effective, supposed to prepare me to do the best and most effective everything every time, had kind of completely left this out. Like it is nuts. That when we were being taught about diabetes in medical school, no one mentioned metabolic bariatric surgery. It's still not in the algorithm for diabetes management. And it's like, this is the cheapest, most effective way to keep people with diabetes alive. How is this not somewhere in there? So that sort of stuff, I was furiously, but it was actually my patients that taught me or allowed me to swap my frame of reference. And then I was like a sponge, because I was like, oh, I love learning about stuff I don't understand, and that was cool. But that's what it came from. And I think that's why, I've talked to you 100 times. This is why your stories matter. And this is why more people who have been through this journey, who have seen both sides, who understand it, need to be talking and making decisions about it. Because this is one area of medicine where people think that because they don't need it, they can block others from having it. I don't need breast cancer treatment. The chance of me ever needing breast cancer treatment is very, very low as a man. But I think breast cancer treatment is really freaking important.
100%.
I don't have obesity. realistically, looking at my family tree, barring something I haven't thought of yet, I am not going to need metabolic or bariatric surgery or obesity management medications at any time in my life. But it's black and white that both of these things save lives, help people live longer, and are worthwhile doing. So I will support them. And yes, I'll also support cancer surgery and all that sort of stuff. But the reason you only hear me talking about this is there's so many other clever people out raising awareness, raising funds, improving resources in cancer care, that I would be one voice amongst many. And I think that in this space, if I talk about this, maybe it's a smaller group, maybe I'm having a more of an impact, I hope.
Yeah.
So that's how I want to use my voice, even though it's not, sort of the biggest part of my clinical work. I think it's where my voice has probably more value, and mainly to stand behind people like you and say, listen to these guys.
And, I think that's what we're so grateful for, is there does seem to be an increasing amount of doctors, surgeons, allied health professionals that are standing up and saying, we do need to listen to the lived experience voice. We need to give them a voice, because it seems that there's been so many, I guess, policies put in place based out of an old bias that people have had, that, lazy and don't eat well. And they've done it to themselves, and it almost to a point, and I've had this from some professionals, almost that if you're living with obesity, or if you're the size that you are and you're not doing anything about it, then I don't want to hear your opinion, because you're obviously not smart enough to.
Yeah, you haven't fixed this for yourself, so you're a failure, so you must not know about this, so your opinion doesn't count.
Yeah, I'm smarter than you.
Bonkers, isn't it? It's kind of the same in other stigmatized areas of medicine. We saw this with HIV/AIDS.
Yes.
Right? Everyone, in the 80s, we saw this, where a similar sort of thing. Oh, well, you have HIV/AIDS, but your opinion doesn't matter because you were dumb enough to catch HIV/AIDS. That was kind of the attitude, right? Yeah. Eesh. Problematic in today's world.
I mean, anyone who grew up sort of in that time remembers the terrible ads that they used to have on the Grim Reaper and all that sort of stuff, and it was
and so there's an interesting, so another example, I think that's a good one, that I think is a path we can follow, is I still remember when I was an intern, I went to a medical grand rounds at St. Vincent Hospital, and they were talking about how they could now eradicate hepatitis C.
Yep.
So the antivirals had got so good that people with hepatitis C, you could treat it and it could go away, which was really cool. Like, someone's presenting this evidence and the potential cost benefits and the life-saving benefits and all those sorts of things, right? And I remember walking out of that and hearing a conversation between a physician and a surgeon.
Yep.
Respectable, intelligent, good dudes. This is not about their attitudes. It's about the cultural norm.
Yep.
And one of them saying the other, like, oh, so that's how we're going to spend taxpayers' money now. All of the bogans with a shit tattoo from Bali and the druggies are going to take my taxes, right? That was kind of, I'm paraphrasing. I don't know what the actual thing, and it probably was a little bit less confronting than that. And that, in that room, was probably the extreme end of kind of a held viewpoint, that it was like, oh, well, Now, over the time since then, there has been a really sustained effort to show that people with hepatitis C, however they get it, are normal people worthy of dignity and respect and medical treatment.
Yep.
And if you treat that and prevent the downstream disease, that's a good and effective way to use taxpayers' money.
Yep.
Now, hepatitis C eradication is significantly more expensive than metabolic bariatric surgery.
Yeah.
So the only fundamental difference there, it's not about the health economics there, and it's not about the impact. Similar impact, about 60 to 70% reduction in mortality. So similar to metabolic surgery for type 2 diabetes, a similar impact. The difference is a group of gastroenterologists mainly, but also other clinicians, and a group of people affected by the disease really went about saying, hey, let's step back with a bit of the judgment, and let's just be objective here. They didn't ask people to treat people with hepatitis C differently or better, or put them up on a pedestal, or make them famous or anything like that. They just said, no, just be objective. Just put the bias aside enough to look at the numbers. That's all they asked for. And now we have a government-funded hepatitis C eradication program and fuck all access to metabolic bariatric surgery. So that's the point. And part of that too is then, if you are diagnosed with hepatitis C, you kind of expect your GP to talk to you about eradication. Doesn't mean you have to have it. It doesn't mean you have to go ahead of it. But it's like, well, man, you got hepatitis C. Let me send you to an expert in this area, because we need to talk about that as an option to you. Life-threatening obesity, there's really no impetus on anyone at any point to say, hey, there is a really effective therapy here we should probably talk about. There's no impetus on all the hospitals that could be providing it to provide it. Let alone the wraparound care you need and all that sort of stuff. Forget about it. None of that, right? So I think that's a story that we perhaps could follow, where really, to me, again, that message with people with obesity that I have met are not asking for special treatment. I've never met one that expects to be treated better or different. But it scares me how grateful they are when they get standard routine care. The hugs and the kisses and the tears and the gifts for just doing the basic job right is worrying to me. That tells me that underlies a lot of mistreatment and delay and discrimination and prejudice in our hospital system.
So I mean, even though we've made so much progress, there's still such a long way to go.
Yeah. And so, I mean, we're here at the repat, I do a lot of surgery in the private system, and that is, our Rolls-Royce care model. As I said, I work with a really cool setup, and I can provide, I truly stand by us providing world-class treatment there to a level that most others practices can't meet. And I'm happy to go on record saying that. Here at the repat, we do a very different thing. I consider this a testing ground for what could we do? What could we do practically, sustainably tomorrow to change this at a bigger level? And so here at this hospital, we don't have an intensive care unit. We don't have any advanced medical doctors working here overnight. When I don't want to scare you in case you do have surgery, but I want to actually, I want to tell you why you should have faith in the system. Actually, we are a very low resource environment. We run on the smell of an oily rag. And so what we have managed to do with that is show that we can very safely, effectively, and reliably choose a group of patients for whom this surgery is highly impactful, saving not just their life and their health, but also money for the healthcare system in an environment with very low resource and no safety net. I mean, we've got an ambulance that can come and all that, don't get me wrong. But we've shown that we can do this in that environment. And to me, that means if I can do it here, then any regional center can do this as well. And I can teach them how to do it. And we're very happy to do that. And I don't mean the surgery, because in a lot of these regional centers, you have very good metabolic bariatric surgeons operating in a private hospital, sometimes employed by a public hospital that refuses to let them do this. Right. And so that's kind of where I see this, and where that's kind of my love for this is more of that big picture thing. It's like, well, not that I think they should copy what we do here, but I think they should learn from the way we develop this here and do it in their own centers. And so I'm part of my, I guess, volunteer activity in this space is I now am regularly in contact with a number of regional centers around the country, working towards like, what could this look like? What are the resources you've got? And there are parts of this that can be very flexibly delivered. There are, and that kind of thing. But then also, showing to the government too that, there is a way to make this so cheap it's stupid not to do it.
Yeah.
So effective that it's negligent not to do it.
Yeah.
And so boringly safe that you wondered why you weren't doing it years ago.